So today we are going to discuss about the mesentery. What exactly is the structure? As you can see, this is the anatomy of the abdomen. So you can see this fold which appears like a frock or a skirt, right? So this fold actually connects the small intestine to the posterior abdominal wall. So this is the fold which is called the mesentery, right? So this is the picture you can see. So these are the small intestine, and these are the mesentery that helps to connect it. So this is the gross image. So in this topic we are going to in this module we are going to see about the mesenteric cyst, panniculitis, malignancy and trauma. These are the four important things that are covered in the mesentery, and there's one more entity called the acute mesenteric lymphadenitis. Lymphadenitis. So as we all know, what exactly is lymphadenitis? It is nothing but inflammation of the lymph node, right? So the mesenteric lymph nodes are inflamed. So you can see signs of obstruction or mass abdomen, right? If one lymph node is inflamed, there can be evidences of inflammation of other lymph nodes also. And this is also called as nurse syndrome, right? So this is one more thing that you are supposed to remember. And the only treatment for this is if there is pain, you have to give analgesics, and then you have to give adequate bed rest and reassurance. If there is severe obstruction, you can also go for laparoscopy and do some appendicectomy, right? So now we are going to start with mesenteric trauma. So trauma, what all types of trauma can actually lead to any mesenteric tear? So mesentery connects the small intestine to the posterior abdominal wall. Any blunt trauma, any blow from behind, or blow usually behind, it is safeguarded by the vertebral column, so any blow from front can lead to a tear in the mesentery. Or if there is any penetrating injury, a stab wound, you can have these tears. Okay, so once there is an abdominal injury, a tear, something has happened inside the abdomen. So how does the abdomen react? There will be lots of inflammation going on. There can also be bleeding that can happen. So all this leads to symptoms of shock. Okay, so the patient will, due to internal bleeding, the patient can present with pallor. And also there is a lot of inflammation that is going on within. There can be abdominal distension and pain. Okay, so all these are nothing but features of peritonitis, right? So definitely if there is something going inside the abdomen which is irritating the whole peritoneum, it will lead to features of peritonitis. So you will have guarding and rigidity, right? So what are the investigation? You will a patient comes with you with abdominal pain. You are going to ask him history, and then you are going to see clinically, and then you are going to do one investigation which is very handy, which is ultrasonogram. So you will take an USG, and then a confirmatory one is CT abdomen, right? So after you take these investigation, you identified with history, you found the type of injury, and with symptoms you localize the region. Now you are doing investigation, you exactly found, but what are you going to see in this investigation? So these are the tears that you can see, right? So either the tear can be a horizontal mesenteric tear, or it can be a longitudinal mesenteric tear. Okay, as you can see, when there is a horizontal tear, lots of blood vessels are being disrupted. So this leads to bowel segment ischemia, right? So when there is a bowel segment ischemia, in order to treat this condition, you have to do only one thing. You are going to go laparoscopically, and you are going to resect the necrosed part, and then you are going to reanastomose it. Anastomose the leftover bowels, right? So when there is a longitudinal tear, you can see lots of blood vessels are spared. So there is not much of bowel necrosis. So you can simply suture the tear. So we usually use the vehicle suture, and it is in the form of an interrupted suture. Okay. So this is all we need to know about the mesenteric trauma. Now we are going to the topic called mesenteric cyst. So as you can see, this is the mesentery. Okay, as you can see, this is the mesentery. The mesentery helps to connect your bowel to the posterior abdomen. So there can be cyst anywhere. Okay, so these are the forms of cyst. So we have 4 basic forms of cyst. It can be a chyle-lymphatic cyst. Chyle, lymphatic, which clearly indicates that it is formed in the lymph nodes or the lymphatics. Right. Next you have the enterogenous. Enterogenous. So enterogenous is nothing but small intestines. Next you have cyst of the urogenital remnant and the teratomatous dermoid cyst. These two are the one which you should know in detail and most commonly seen. There can be other cysts also, like you can have a traumatic hematoma, right? And also there can be tuberculous cold abscess. And definitely you can see hydatid cyst. Hydatid cyst, you can see it anywhere. So these are the lymph nodes and the lymphatic drainage. A cyst can occur anywhere over here. And these are called as nothing but chyle-lymphatic cysts. Okay. Moving on to how it actually looks. So as you can see, this is how a chyle-lymphatic cyst present, and this is how an enterogenous cyst present. A chyle-lymphatic cyst is present in the mesentery. It has no connection with the bowel, and it has a separate blood supply, as you can see. It does not take the blood supply of the intestine. Okay, so what is the site? You can see it mostly in the ileum. Okay, in and around the ileum you can see, because it has rich lymphatics, Peyer's patches, and there are lots of lymphatics in the ileum. And what is whereas in the enterogenous cyst you can see it involved with the small intestines, right? So it can involve any part of the small intestine. And what type of cyst can it be? So since it does not contain any part of bowel, the chyle-lymphatic cyst does not contain any part of bowel, it forms a thin cyst wall. Okay, and this cyst is a part of the bowel. So the cyst wall is very thick. And the content, chyle-lymphatic, obviously you're going to contain, it contains chyle or the lymphatics. And in this enterogenous cyst, the content is the same as that of the bowel, and it consists of all 3 layers of the bowel. Now the blood supply. It has a separate blood supply, as you can see, and the enterogenous cyst has the same blood supply as the bowel. So why is this necessary? This helps in the management, because how you're going to manage a chyle-lymphatic cyst? You're simply going to remove the cyst. You're going to enucleate it, right? Whereas when there is an enterogenous cyst, you have to resect the whole part of the bowel along with the blood supply and the cyst. This is how the management actually differs. So that is why you need to know these two importantly. So next we are going to see the features. So as you can see, this is the cyst. Okay, so as you can see, this is the cyst, and this cyst is attached to the line of attachment of mesentery. We know anatomy. So it attaches, the mesentery attaches to the posterior abdominal wall in this direction. Okay, so the cyst that is developing from the mesentery is outpouching like this. So when it moves, it will move in a perpendicular direction to the attachment. It can't move in the same plane. So it always moves in a vertical direction. In a perpendicular direction. Okay. So there is something that you have to know, which is called Tilloch's triad. This is the most important, the only thing you should know about mesenteric cyst. First of all, the triad consists of soft fluctuating swelling. Secondly, it should be mobile in perpendicular direction to the mesentery, and the zone of resonance around a dull node. So basically, the swelling is fluctuant. Obviously, there is this line of attachment and there is one swelling, a cystic swelling. It will be fluctuant and it is soft, and obviously it's a swelling. Second, as we saw in this, it is mobile in perpendicular direction to the mesentery. And thirdly, there will be a dull node around the cyst, but surrounding the cyst you have the bowel. So obviously it will be resonant. So what it is, there is a zone of resonance around the dull note. So this is the triad called Tillock's triad that you should know. Okay, moving on to complication. So as you know that this is a cyst, and what all can happen to a cyst. So first of all, the cyst can go into torsion. It moves a lot, so it can go into torsion. A cyst can rupture. There can be hemorrhage inside a cyst, and there can be definitely infections, and it can form a pus also, right? So this is how we completed the mesenteric cyst. Moving on to the next topic, which is mesenteric panniculitis. So as you all know, panniculitis, what is this term panniculitis? Panniculitis is nothing but it is the inflammation of fat. So the fat in the mesentery is getting inflamed. That is called the mesenteric panniculitis. So it is defined as it is an inflammatory disease of the mesentery. As you can see, inflammatory disease of the mesentery with there is fat necrosis, there is acute or chronic inflammation, and fibrosis. Definitely when there is a necrosis, there will be some sort of inflammation, and then long duration of inflammation can lead to fibrosis. Okay, this is what exactly is mesenteric panniculitis. So this can be associated with syndromes or diseases like Weber-Christian disease, mesenteric lipodystrophy, and lipogranuloma. This is Weber-Christian is a autoimmune disease. Okay, autoimmune fat related disease, and also you have this mesenteric lipodystrophy and lipogranuloma. So what are the features? There is some inflammation going in. You will have a recurrent abdominal pain. There is obstruction. You have abdominal distension. The abdomen becomes tender and has a resonant mass. Okay, so all these are features of mesenteric panniculitis. What is going to be the investigation? You know there's an inflammation. So what are you going to order? ESR and CRP. These are the things which you are going to order whenever there's an inflammation. And one more thing that you should know about this condition is on CT, you're going to find a fat ring sign. So there is a mesenteric vessel, as you can see here, and surrounding there is a mesenteric vessel, and surrounding the vessel you have a normal adipose tissue, which on CT you can see as fat ring sign. This is one important stuff you should know. And what are the differential diagnoses? It can be a carcinoma, any carcinomatosis, a peritoneal carcinomatosis, or carcinoid syndrome, or mesenteric sarcoma, mesenteric TB. Obviously, DD for cancer is tuberculosis, right? So it can be mesenteric TB or intestinal obstruction. These are the things you should know about mesenteric panniculitis. And lastly, we are going to talk about the mesenteric malignancy. The most common malignancy is nothing but secondaries, and that too from the GI adenocarcinoma. Okay, so how can this spread? It can be a direct spread, it can be from the lymphatics, or it can be transperitoneal, right? So if we talk about the primary tumors, so primary tumors, we have two tumors which are primary. First is the mesenteric desmoid. This is the most common primary tumor of the mesentery. Okay, the most common tumor is the secondaries, but the most common primary tumor is the mesenteric desmoid, and it is very aggressive. It is associated with FAP, that is familiar polyposis, adenomatous polyposis, and Gardner syndrome. Okay, and then we have the other tumor, which is nothing but mesenteric lymphoma. Obviously, there are a lot of lymph nodes in the mesentery, and it can form malignant. It can take a malignant form and form a lymphoma. So how will you manage a mesenteric lymphoma? Via chemotherapy, obviously. So this is we completed the mesenteric lymphoma. Now we are going to see mesenteric desmoid. So it is an aggressive tumor, and it is seen in these conditions. So next we are going to see what are the complications it can go into. Since it's a tumor, it's a mass, right? So when there is a mass, what you can see? It can go develop obstruction. So intestinal obstruction. When there is an obstruction, what is going to happen? There can be necrosis. When there is necrosis, what is going to happen? It can eventually perforate, right? And there can also be other complications like bleeding and stuffs. And all this leads to intense abdominal pain, peritonitis feature. Okay. And how we are going to find it out? We are going to do a CT abdomen. obviously any abdominal condition, CT used to be the investigation of choice, right? So we're going to do CT abdomen, and you can even do lab. And then one more thing, since it's a malignancy, you have to take a biopsy. Okay, how are you going to manage? Definitely to get relief, surgery is your primary management. But since it's a malignant tumor, there is increased chances of recurrence. A GI malignancy always has increased chance of recurrence. So what we have some medical therapy for this condition. So we have Sulindac. Sulindac is nothing but COX-2, COX-1 inhibitor, that is prostaglandin inhibitor, and you can give anti-estrogens, and you can also give imatinib. Right. So let's see a summary of what we did so far. So this is the mesentery. It's the fold that connects the small intestine to the posterior abdominal wall. And then we are going to see about, and we saw about mesenteric cyst, panniculitis, malignancy, and trauma. So trauma, a blunt trauma, and the patient can present with signs of peritonitis. The investigation, you are going to take an ultrasound and CT abdomen. When there is a horizontal trauma, there will be bowel necrosis. So when there is a horizontal trauma, there will be bowel necrosis. So you have to resect the resect, and the leftover bowel is anastomosed. When there is a vertical tear, there is going to be no bowel ischemia. So you are going to simply suture it with a interrupted suture. So a mesenteric cyst, it can be chylolymphatic or enterogenous, and other types are cyst of the urogenital remnant and teratomatous dermoid cyst. A chylolymphatic has its own blood supply. It is away from the intestine. It is thin-walled, right? And it contains chyle as a content, whereas the enterogenous cyst is a part of the small intestine. So you have to resect the whole along with the bowel and the blood supply in order to save the intestines. And whereas in a chylolymphatic, you have to simply enucleate the cyst, right? And one more important thing is the Tilloch's triad, which is about the swelling. First of all, it's a soft fluctuant swelling, and it is mobile in perpendicular direction to the mesentery, and there is a zone of resonance here, there is a zone of dullness in the cyst, followed by a zone of resonance surrounding it. So this is the Tilloch's triad. And the complication, obviously a complication that any cyst can go into is torsion, rupture, hemorrhage, and infection. This is about the cyst. Panniculitis is inflammation of the fat. There is inflammation of the mesentery, fat necrosis, acute and chronic inflammation, and this chronic inflammation can lead to fibrosis. And these are the syndrome associated with it. They can be pain, obstruction, distension, tender and resonant mass. So you are going to check the inflammatory markers, ESR, CRP, and then there is a fat ring sign. That is a vessel surrounded by normal adipose tissue deposition. Okay. Now we saw mesenteric malignancy. In the mesenteric malignancy, most common is the secondaries, but primary tumor, most common is the mesenteric desmoid. And the complication it can lead to is obstruction, necrosis, and perforation. And obviously, it is related with the FAP syndrome and the Gardner syndrome. How are you going to manage? Surgery, but there is high recurrence. So you are going to do Sulindac. You can give Sulindac, anti-estrogen, and imatinib. Okay. Thank you.